2020 was memorable with the path-breaking clinical data presented from multiple global trials, and this program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which would bring upon two different ways to address various complexities of the heart failure. And so according to Empagliflozin trial, thus SGLT2 inhibitor can be considered as an important drug for HFrEF. And for this, let me introduce today's speakers. Yeah, today's speakers are Dr. Satyendra Routray and Dr. Abhay Kumar Sahoo. And I will moderate Dr. Shovik. Dr. Abhay Kumar Sahoo is a professor in endocrinology at IMS and ECM Hostel Bhubaneswar and has several national and international publications in his credit and also received several prestigious awards. I welcome Dr. Abhay Kumar Sahoo in this expert workshop. Our next speaker is Dr. S.N. Routray. Dr. Routray has more than 70 publications in different national and international journals and also contributed chapters in various books and also contributed chapters in cardiology and medicine updates and also examiner and MCI assessor in DM and DNB students for the cardiology and a reviewer of many and also a fellow of ACC, ESC, SCI, CSI and ICC. I welcome Dr. Routray in this expert webtalk and I've handed over the session to Dr. Abhay to start with the presentation. Thank you. Vinay, share the presentation.
Yeah, thank you, friends. Today we are going to discuss empagliflozin, the multi-mechanism, multi-indication, and the multi-benefits. And we'll have two discussions. I'll discuss about the endocrine perspective and diabetic perspective of particularly this empagliflozin, whereas Dr. Satya Routray sir will discuss the particularly cardiovascular perspective, particularly this empagliflozin. So next, so SGLT2 inhibitors, they modulates a large range of factors related to the cardiovascular risk. Based on the clinical and mechanistic studies, what we have got, still we are a bit puzzled because it has a lot of benefits on every part. You will see the blood pressure reduces, arterial stiffness reduces, it causes reduction in albuminuria, it causes reduction in uric acid, both glucose and insulin content is reduced, oxidative stress is reduced, but it has some effect like increase in LDL cholesterol and HDL cholesterol, but triglyceride is significantly reduced. And what we discuss usually that this increase in LDL cholesterol is the large bond particles, not the small dense particle, which is responsible for atherosclerosis or accelerated atherosclerosis. Again, it has good property like it causes weight loss with the reduction in the visceral adipose tissue, and also it reduces the particularly sympathetic nervous system activities or sympathetic tone is reduced, particularly use of this SGLT2 inhibitors. So let us see these beneficial effects of SGLT2 may complement or improve. Next, may complement or improve the effects of the mainstay heart failure medications. If you see the heart failure medications, we have ACE inhibitors or ARB, then we have ARNI, beta blockers, particularly this mineralocorticoid receptor agonists, then diuretics, then SGLT2 receptors. Among these, you will see who are the drugs like natriuresis, kidney function or altering the cardiorenal physiology, decreases the preload, afterload, or left ventricular wall stress. All three together, then probably ACE inhibitor ARBs, ARNI, and SGLT2 are the three drugs which is equally effective for all three drugs. But if we'll discuss about the interstitial edema, on top of that, only particularly SGLT2 is the drug having reduction in the capacity of reducing the interstitial edema. So if we combine SGLT2 with other particularly this heart failure medications, probably it will be complementary to each other. Probably it can further improve the outcome of particularly heart failure patients among the diabetics. If you see the SGLT2 inhibitors, what is the published strength of evidence? DAPA first publication in March 2008. Then subsequently there are more than 500 publications on DAPA. Then Empagliflozin in October 2008 first. Then canagliflozin is September 2010. Then Empagliflozin is June 2012. And we have actually, after that, we have multiple publications. Next, we have multiple publications, and all those publications gives us good sort of strength that this DAPA, hemogliflozin, canagliflozin, empagliflozin can be used in different setups, in different clinical settings without any hesitation, and we can use in different clinical areas related to diabetes. Even if in diabetes is a monotherapy or in combination to other therapies, it can be used. Next. So if you see the urinary glucose restriction via SGLT2 inhibitors, normally almost close to 180 grams of glucose is filtered daily. And if you are giving SGLT2, then all those 180 grams will come down through urine, but should come down through urine. But SGLT1 is the part which plays some sort of critical role and also helps reabsorption of some sort of minimal amount of glucose. So close to 100 gram of glucose usually excreted if you are blocking the SGLT2. And that reduces the glucose reabsorption in the proximal tubule. That leads to increase in the urinary glucose excretion. Also that leads to osmotic diabetes. Next. So if you see the pharmacological properties of available SGLT2 inhibitors, empagliflozin versus dapagliflozin versus canagliflozin, usually the therapeutic dose of empa is 10 to 25 milligram, dapa is 5 to 10, and canagliflozin is 100 to 300 milligram. All is single daily dosing and not related to food. And almost every drug, empa is 1.5 peak is at 1.5 hours. Again, dapa and cana, again the peak is within 2 hours. And half-life is close to same. When empa it is 12.4, dapa it is 12.9, and it is canagliflozin, it is 13.1. And the selectivity to SGLT1 is 1 in 5,000 for empagliflozin, 1 in 1,400 in dapagliflozin, and 1 is to 160 is with product canagliflozin. Next. So if you see the empagliflozin, the pooled phase 3 placebo control corrected change in HbA1c or different as a monotherapy with metformin, with pioglitazone, with metformin plus sulfonylurea combination, with insulin, or with any sort of therapies. Everywhere, people see empagliflozin 10 milligram causes a particularly HbA1c reduction of 0.62% to 0.5%, whereas empagliflozin 25 milligram can cause a HbA1c reduction of almost 0.7 to 0.9 milligram percent. So there is a significant reduction in HbA1c, whether it is used in monotherapy or in combination with different drugs. Again, if you want to see what is happening to the body weight, even if you give 10 milligram or 25 milligram, everywhere in 10 milligram range, the weight loss is around 2 to 2.5 kg, whereas in 25 milligram, the weight loss is between 2.5 to 4 kg, or maximum weight loss is 4 kg, with particularly use of empagliflozin 25 milligram. Next, again, if you want to see the particularly the blood pressure reduction, the systolic blood pressure reduction is as high as 3 to 4 millimeter mercury across everywhere, whether it is metformin, pioglitazone, or metformin sulfonylurea combination. But with insulin, usually this blood pressure lowering is not available. But across the range, it is actually the reduction of systolic is around 4 to 5 millimeter mercury. And this is a beautiful study. Next, where a 12-week ABPM was done. Next, a 12-week ABPM study was done with empagliflozin in patients with type 2 diabetes with hypertension, with hourly monitoring of the systolic blood pressure. What they found in comparison to placebo, empagliflozin 10 and 25 milligram, both at 12 weeks. You see the upper one is particularly the baseline, whereas in the lower one at 12 weeks, you see the placebo is in the upper part, where both empagliflozin 10 and this blue line and red line both are showing a significant reduction in systolic blood pressure. And there is, you see, the area time between particularly the midnight time, particularly there is a significant the blood pressure drop which happens, that is also well preserved. There is no significant fall is not there. So that means throughout the day, it maintains a steady state of reduction in blood pressure throughout the day without hampering particularly this night sudden dip in the blood pressure. Again, you will see the empagliflozin ABPM for the diastolic point of view. Again, over a period of 12 weeks, you see the upper one is the placebo group, where this blue and red one is empagliflozin 10 milligram and 25 milligram respectively in comparison to placebo. Next, in comparison to the placebo, there is a good reduction of the diastolic blood pressure is there over a period of 12 weeks. So both empagliflozin is responsible for reduction in both systolic and diastolic blood pressure significantly. And that is one of the important pleiotropic benefit that gives some sort of additional benefit on top of particularly diabetes management. Next. So what is happening to the empagliflozin to the lipid profile? You will see the first one is particularly LDL cholesterol. It increases both in 10 and 25 milligram. The HDL cholesterol again both increases with 10 and 25 milligram. But there is a significant drop in triglyceride, which is both from 10 and 25 milligram. And so, since both LDL and HDL cholesterol increases, so LDL to HDL ratio is well preserved. Again, as I have already discussed in the beginning, the LDL cholesterol which increases, these are the large buoyant particles, these are not small dense particles. So probably it has not that type of detrimental effect on the lipid profile point of view. Next. So people see the effect of SGLT2 on glucose control, body weight control, and systolic blood pressure control. As a monotherapy, we have a lot of RCTs which has shown that particularly if you see the body weight reduction and if you see the fasting, everything is significantly reduced. If you see add on to metformin, again we have 9 studies which has got significantly both HbA1c, fasting, and body weight, systolic blood pressure, everything is significantly improved. On sulfonylurea with SGLT2, so all those data has clearly shown that whether you give as a monotherapy, whether you give SGLT2 with metformin or sulfonylurea, the HbA1c lowering property, the blood glucose lowering property, the body weight lowering property, and the blood pressure lowering property, everything is well preserved, well maintained throughout the particularly all group of areas or with all group of drugs. Next. So empagliflozin pooled safety and tolerability data, summary of adverse events. You will see that any sort of adverse events in the placebo is particularly probably higher number in comparison to the empagliflozin 10 milligram and 25 milligram. You will see the patients with any sort of adverse events, but patients with adverse events that lead to discontinuation of drug is very, very minimal. In the placebo group, it is 6.4, whereas in the EMPA group, it is 4.5 to 5 group, 5. And you will see the serious adverse events, again, in the placebo group is higher in comparison to empagliflozin. So we can safely tell that the number of side effects in empagliflozin is significantly less, or it is at par with placebo in comparison to the other events what is happening to the other group. So the pooled empagliflozin data, which is important, identifying the safety. So it will see the comparison of placebo versus empagliflozin 10 and 25 milligram. Probably next, probably the few side effects which is found more in particularly EMPA group in comparison to placebo. This is the genital infection. This genital infection, whether it is female or male, both is significantly higher in empagliflozin group. Again, you will see the genital mycotic infection. Again, this is higher. But fortunately, you will see the pyelonephritis, urosepsis, and particularly acute pyelonephritis. All are it is at par with placebo, or in the otherwise, placebo are actually numerically more number in comparison to the empagliflozin group. Again, you will see the volume depletion part. There also it is actually almost equal in placebo is comparable to empagliflozin. So only the genital mycotic infection or genital local infection is a little bit higher with empagliflozin 10 and 25 milligram. Next. So let us discuss the initial outcome empagliflozin cardiovascular outcome in patients with type 2 diabetes at high risk cardiovascular risk, or this EMPA-REG outcome trial. So here, if the EMPA-REG outcome trial from the renal outcome point of view, next renal outcome point of view. So here the incidence or worsening of the nephropathy is significantly less in particularly empagliflozin. The deep blue one is EMPA and light blue is the placebo group. So with a hazard ratio of 0.61, that means there is a 39% reduction in the EMPA group in comparison to placebo. If you see progression to macroalbuminuria, that is actually reduced again by 38% more in empagliflozin in comparison to the placebo group. And if you see take the composite outcome, the hazard ratio is 0.54. That means in EMPA group, there is almost a 46% reduction in the composite renal outcome in comparison to the placebo group. Next. So in patients with type 2 diabetes on high CV risk, empagliflozin given in addition to standard care reduces the heart failure, hospitalization, also CV death with a consistent benefit observed both in those with or without heart failure at baseline. That means, so those who are having a baseline heart failure or those having no baseline heart failure, both are getting benefit of empagliflozin used from that point of view. So if you see the empiric outcome, next outcome, then there is a significant reduction in the 3-point MACE and cardiovascular death. You will see the 3-point MACE, the people is statistically significant. Cardiovascular death, again, it is very, very significant. Non-fatal MI, the people is not significant, but still it is actually giving benefit. And if you see the non-fatal stroke, it is actually more little bit higher in empiric. But again, in the subsequent trials, it has been nullified or it has been refuted that empagliflozin increases the risk of particularly the stroke. So this is the clear-cut study has clear 3-point MACE and CV death has significantly improved with empagliflozin or use of empagliflozin. Next. So how early after treatment initiation of CV benefits or empagliflozin is apparent? This is the post-hoc analysis of empiric outcome, which has clearly shown if you are using empagliflozin or in the empiric outcome trial, these CV benefits with an early separation of both the incidence score was very much as early as within 4 weeks. You can imagine very rapidly there is a wide diversion of both the curves. So the explore at what time point after randomization benefit becomes apparent and the hazard ratio stabilized as number of patients with events increased over time. The benefits of empagliflozin in reducing particularly hospitalization due to heart failure, CV death, or hospitalization heart failure combination, or CV death alone emerged within weeks after treating or treatment initiation in the empiric trial or within weeks of initiating this empagliflozin. If you will see how early, next, how early after treatment initiation the CV benefit comes, a post-hoc analysis has clearly shown the reduction in the risk of empagliflozin versus placebo reached a significant at day 17 for heart failure. So within 17 days of initiation, the hospitalization due to heart failure is reduced. By 27th day, the CV death and hospitalization due to heart failure combined together is getting the benefit, and a sustained significant throughout follow-up is found subsequently. And if we take benefits of CV death alone, then probably it is the 59th day which is started giving benefit after 59th day. So if you're seeing the only heart failure, it is 17 day. Heart failure, CV death combination, it is probably the 27th day. And also if you check the CV benefit, then it is probably the 59th day. That is the benefits is starting. Again, the effectiveness and safety of empagliflozin in routine care patients, interim results of empagliflozin, comparative effectiveness and safety, that is EMPRISE trial. This is one of the beautiful study where the empagliflozin is directly compared with DP4, specifically sitagliptin. And this is a active comparator. So here empagliflozin is not compared with any sort of placebo group. What they found, even if with comparison to DP4, specifically sitagliptin, the hospitalization to heart failure is significantly less. If you take hospitalization due to heart failure in a broad term, that is also significantly less in the empagliflozin in comparison to DP4. Myocardial infarction and stroke, it is giving benefits to the empagliflozin, but it is close to the midline. And if you see the ischemic or hemorrhagic stroke, again it is giving benefit to the EMPA group. And if you see the all-cause mortality, there is a significant benefit with empagliflozin. So, EMPRISE trial where empagliflozin is directly compared with a active comparator. Next, directly compared with an active comparator has clearly shown that benefit within few days. The risk of MI, the risk of stroke in the routine clinical care, it is significantly getting benefit with the use of empagliflozin in comparison to DP4 inhibitors. And a subset of population with complete mortality information, empagliflozin is associated with a decreased risk of all-cause mortality compared to DP4 inhibitors. So this is the EMPRISE is a directly comparison of EMPRISE DP4, specifically majority of people with sitagliptin, and it has clearly shown again empagliflozin is far ahead with comparison to DP4 inhibitors. Next. So the CV safety trials are being conducted for each compound within the newer classes. You will see particularly the blue classes. These blue classes are particularly with DP4 inhibitors. These are DP4 CBOTs, that is Severtimi, Examine, Tecos, then Omenon, and Carmelina and Carolina. Again, these are almost all are neutral from CV point of view, and particularly this Severtimi has shown there is increase in the hospitals due to heart failure. If you see the SGLT2 inhibitor CBOT, these are all red like Emparec, then Canvas R, Canvas, Credence, Declartimi, then again with Empagliflozin, there is Empagliflozin CBOT, all have come and all has given benefit of heart failure point of view. Of course, if you see the cardiovascular benefit or CV death benefit, Empagliflozin is the only drug has given, but 3-point MACE again all are given benefit. So CV death benefit is we are getting from the Empagliflozin point of view. And again, there are certain trials like EMPA-HEART trial and EMPRISE trial, which has actually given again boost our confidence from that point of view. My next speaker will, Satya sir will actually discuss that part a little bit. So what the guideline is taking next. So it is a 2018 ADI-ESD consensus report shows that metformin is not necessarily considered as the first line of therapies. Even if in the drug-naive patients or patient on metformin, irrespective of HbA1c level, if someone is having ACVD risk factors, directly you can go for SGLT2 inhibitors or GLP receptor agonist. If patient is high or very high cardiovascular risk factors, again, even if before metformin drug-naive patients, you can directly go for SGLT2 inhibitors or GLP-1 receptor agonists. So with this much, from the cardiovascular point of view, Satya sir will discuss that part. From the endocrine point of view, from the diabetes point of view, so I am actually from.
Hello, good evening, everybody. I think I will continue with this presentation. I can, no problem. Yeah.
Yes, sir.
So you'll have to go change the slide. Next. If you see this slide, this was the exploratory data showed by the SGLT2 inhibitors have many cardiorenal benefit. You see, heart failure hospitalization, CV death, kidney outcome, all here in Emparec is more around 35 to 39%, all are very high. Whereas in canagliflozin, dapagliflozin or empagliflozin, you see the heart failure hospitalization is equally high in all gliflozins, all SGLT2 inhibitors, whereas CV death benefit is particularly found in this Emparec outcome, which was explained very clearly by Dr. Sahoo. And the kidney outcome is also equally good with EMPA, CANA, and DAPA. But only CV death, particularly if here, if the established cardiovascular disease, the benefit is definitely more with empagliflozin. Next. This Emparec outcome trial, this is what Dr. Sahoo explained. This is the total, the 3-point MACE. Here is CV death and death from any cause and hospitalization for heart failure. If you see, P value for CV death is less than 0.001. For heart failure hospitalization is equal to 0.002, and death from any cause is less than 0.001. So definitely there is mortality benefit and hospitalization for heart failure benefit is there found in the Emparec outcome trial. Next. This is the Framingham study, which was a high rate of heart failure in patients with diabetes over 30 years of follow-up. They found, you see, total cardiovascular disease, this is coronary heart disease, and cardiac failure, intermittent claudication representing peripheral vascular disease. All these things are higher, particularly in women, whereas a stroke, CV stroke is higher in men. But if you see, cardiac failure, the most common, particularly if there is diabetes. Next. These are the trials, which heart failure is a more common outcome than MI and stroke and death in diabetes mellitus trial. These are the trials that showed the incidence of heart failure is more, particularly if there is diabetes. Next. This is again, you see, the more or less intensive glycemic control, the effect on MI and heart failure resulting in hospital admission or death. You see in this Accord, Advance, UKPDS, VADT, all these things this we taken together, there is definite benefit in the more intensive treatment group is if you consider in the development of MI and heart failure events. Next. Whereas you see, if you take drug wise, here equipds, sulfonylurea is used, origin, insulin was used, here thiazolidines were used, GLP-1 analog used, DPP-4, SGLT2 inhibitors. The maximum benefit for heart failure is drug wise, if you see, this is there with the SGLT2 inhibitors. Next. This is what the Empiric outcome trial Dr. Sahoo described clearly. This show the heart failure risk in patients with diabetes, the Empiric outcome trial. They screened 11,531 patients randomized and treated. The placebo here, and here is empagliflozin 10 milligram and empagliflozin 25 milligram. The key inclusion criteria were adults with type 2 diabetes with established cardiovascular disease and BMI less than 45, HbA1c around 10, eGFR more than or equal to 30. Next. You see, the benefit was there in the empagliflozin group where the curve started diverging from the very beginning. This is here months in the first month, the curve started diverging and has been shown by days by Dr. Sahoo in different endpoints. Next. These are the SGLT2 inhibitors, how it affects the multiple pathway in the heart failure. If you see here, this reduces preload. By diuretic effect, it reduces the preload. By afterload, by reducing the hypertension. And reduction of the LV wall stress, by reducing both preload and afterload, it reduces the LV wall stress. And reduces the interstitial edema. That is why it is called as a smart diuretic. It improves the kidney function and cardiorenal physiology, and there are natriuresis. By multiple methods, it helps in improving the heart failure. Next. These are the established drugs. You see, you come to the right side. Therapies for both to treat and prevent heart failure is ACE inhibitor, ARB, beta blocker, and exercise. Therapy is only for established heart failure. This is only for treatment. ARNI, ivabradine, or MRA, and CRT and ICD. If you think of preventing means before developing heart failure, when the high-risk patients, you have to treat those patients where you get the benefit. Statins, controlling the blood pressure with calcium channel blocker thiazides. SGLT2 inhibitor stands here. Now it has come here both preventing and treating. And it's antiplatelet, weight loss, and primary prevention. Next. So this thing was told by Dr. Sahoo. The guideline speaks where to use. Yes, ESC guideline, he told from diabetic point of view. Here is the ESC guideline is a little aggressive. They tell metformin not only considered as a first-line drug therapy in drug-naive patients or patients on metformin, irrespective of the level of HbA1c, if there is ASCVD or high or very high cardiovascular risk, start with SGLT2 inhibitor or GLP-1 analog or add on if the patient is already on metformin. Whereas our ACC-AHA little conservative. They consider metformin as first-line drug therapy. If HbA1c remains more than equal to 7 in patients over cardiovascular disease, the risk factors primarily prevention, and then consider adding SGLT2 inhibitors or GLP-1 analogs. Next. Coming to the Emperor heart failure trial, which we want to emphasize today. Here, this was a e-poster presentation. This actually summarizes how this in Emperor reduced, Emperor preserved. In both cases, they were used. Particularly if ejection fraction is less than 40%, they take into consideration also NT-proBNP in reduced. And in preserved, if the EF is more than 40%, and presence of one or more of the following, that is structural heart disease or heart failure hospitalization in last 12 months prior to screening. Here, elevated NT-proBNP for patients with and without heart failure, without atrial fibrillation were also taken into consideration. Next. Next. Yeah. This is how in Emperor preserved, either this screening period is 28 days, less than 28 days, A randomization of about 6,000 patients, either to empagliflozin 10 or placebo, and follow-up for 24 months, and post-treatment period is 30 days. In Emperor reduced, this screening was less than equal to 28 days, 3,730 patients, Emperor 10, sorry, empagliflozin 10 or placebo, follow for 20 months, and post-treatment period of 30 days. Next. These are the different countries all over North America, Latin America, South Europe, Asia, China, India, Japan, Singapore, South Korea, and Australia. All everywhere there was this study, multi-centric study. Next. What was the conclusion? This Emperor reduced and Emperor preserved trial will determine the efficacy and safety of empagliflozin in patients with heart failure reduced ejection fraction or heart failure preserved ejection fraction respectively. The effects of empagliflozin on symptoms, exercise, and capacity, and patient-reported outcome in patients with heart failure reduced ejection fraction or heart failure preserved ejection fraction are being investigated in Imperial reduced and Imperial preserved trial. Together, these trials are expected to deliver conclusive insights regarding the value of empagliflozin treatment in patients with heart failure. Actually, this e-poster was presented before the final result came. This was in Berlin 2018 after they started this trial. Next. Next, please. Yeah. This is what the ESC 2019, when it was not out, only this was here, this was design. This design was published. Evaluation and effect of SGLT2 inhibitors, empagliflozin on morbidity and mortality in patients with chronic heart failure and reduced ejection fraction, rationale for design of the Emperor reduced trial. By adjusting the eligibility based on the natriuretic peptide levels to baseline ejection fraction, trial will preferentially enroll high-risk patients. They want high-risk patients to be enrolled. A large proportion of expected to have ejection fraction less than 30%, and estimated annual event rate is expected to be at least 15%. Next. What they found? The mechanism that might be responsible for striking cardioprotective benefit with SGLT2 inhibitors were described here. Next. Here, what are the top line results that came? The top line results, the composite primary endpoint, that is time to first event of adjudicated CV, the cardiovascular death or adjudicated heart failure hospitalization in patients with reduced ejection fraction and heart failure reduced ejection fraction was up to 38 months. Composite primary endpoint, that is time to first event of adjudicated CV death or adjudicated heart failure hospitalization in patients with heart failure and reduced ejection fraction. Next. If you come to the details, this was published in August 2020. Next. Yeah. This was, go to the next. Next. Yeah. Here, Emperor reduced trial specified only 3 endpoints to be tested in a hierarchical manner. Primary endpoint was composite of cardiovascular death or heart failure hospitalization. First secondary endpoint was total, that is first and recurrent heart failure hospitalization, total heart failure hospitalization. And second secondary endpoint was slope of decline in glomerular filtration rate over time. So primary is composite of cardiovascular death and heart failure hospitalization. And secondary, the first secondary is total, that is first and recurrent heart failure hospitalization. And secondary, second endpoint was slope of decline in the glomerular filtration rate. Next. Next. Yeah. The Emperor reduced trial showed the empagliflozin is superior to placebo in improving heart failure outcome among patients with symptomatic stable heart failure reduced ejection fraction. They took heart failure reduced ejection less than equal to 40%, patient stable. This acute decompensated heart failure were not included in the study, irrespective of their diabetic status. They're diabetic or non-diabetic, they were enrolled in the study. Next. Yeah. The goal of the trial was to assess the safety and efficacy of empagliflozin in patients with symptomatic heart failure with reduced ejection fraction, irrespective of the diabetes status. Next. So this is a study design. As the patients are randomized in 1-to-1 fashion, either empagliflozin 10 as we discussed in the first slide or matching placebo. All the patients were receiving appropriate treatment for heart failure. All guideline directed heart failure treatment was given. Over and above, empagliflozin was given to one group of patients 10 milligram. Total screen 7,220. Total number enrolled 3730. Duration of follow-up was 16 months median. Mean age of patient 67 years. Percentage of female were 24%. Next. Inclusion criteria: age more than or equal to 18 years, chronic heart failure NYHA class, functional class 2, 3 or 4, LVEF less than or equal to 40%, heart failure hospitalization within 12 months. And here important, the N, they took into account NT-proBNP, N-terminal proBNP, nitric peptide. If it is ejection fraction less than or equal to 30%, it should be more than or equal to 600 picogram per ml. If ejection fraction is 31 to 35%, NT-proBNP should be more than 1000, and ejection fraction 35 to 40, this NT-proBNP should be more than 2500, so that the all patients are high risk. In concomitant, if there is a concomitant atrial fibrillation, then above threshold were doubled. Next. Exclusion: acute coronary syndrome, stroke, transient TIA within 90 days were excluded. Listed orthotopic heart transplant currently implanted on LVAD were excluded. Cardiomyopathy based on infiltrative or accumulative disease, muscular dystrophy, reversible cause, hypertrophic cardiomyopathy, pericardial restriction, peripartum cardiomyopathy caused by chemotherapy, etc. within 12 months were excluded. Severe valvular heart disease excluded. Acute decompensated heart failure excluded. Implantable on patients with ICD or CRT were also excluded. Next. Salient features: whites at 70%, Asians 18%, North American 11%, European 36%. Yes, here this Latin American 34%. NYHA functional class 2, mostly the patients were in NYHA class 2. There are 75%. Mean left ventricular ejection fraction were 27. Type 2 diabetes were present 50% of 50% diabetic, 50% non-diabetic. So estimated glomerular filtration rate is less than 60 were included in the study. The average was 48%. This medications, angiotensin converting enzyme inhibitor, angiotensin receptor blocker were taking 70% taking. Angiotensin neprilysin inhibitor were taking 19%. Mineral corticoid receptor blocker by 71%. Beta blocker 94%. So almost all patients were given guideline-mediated definitive treatment for heart failure. Along and with that, over and above, one group given 10 milligram of empagliflozin compared to the placebo. Next. So principal findings: the primary outcome of cardiovascular death or heart failure hospitalization for empagliflozin versus placebo was 19.4% versus 24.7%. So hazard ratio of 0.75. 95% confidence interval, the p-value is 0.001. Coming to the cardiovascular deaths, if this is a composite of cardiovascular death and heart failure hospitalization, that was the primary outcome. Cardiovascular deaths, if you see 10% versus 10.8%, these are not statistically significant here in this group. Heart failure hospitalization of 13.2 compared to 18.3, this is statistically significant. Next. So, as you see, this composite of cardiovascular death or heart failure hospitalization reduced by 25% and p-value is less than 0.001. First secondary endpoint, that is total heart failure, first and recurrent, reduced by 30%, p-value less than 0.001. Second secondary endpoint, that is slope of decline in glomerular filtration rate over time, was reduced by 50%. The renal events were reduced by 50%. Yeah. Next. Here, how the graph shows. You see, empagliflozin prevented both serious heart failure and serious kidney failure events. Cardiovascular death or hospitalization for heart failure compared to placebo, the graph started diverging from the second week itself, and it was less with empagliflozin compared to the placebo. And this was 25% reduction in the risk. Hazard ratio was 0.75. Your composite renal outcome, as we discussed, there is almost 50% reduction in the risk. The composite, 50% reduction in death, and p value was less than 0.001. Next. So Emperor reduced trial has major implications on clinical practice. The Emperor reduced trial with empagliflozin will have a major impact on the management of patients with chronic heart failure and reduced ejection fraction, whether or not they have diabetes. There is now compelling evidence that SGLT2 inhibitors should now be added to currently recommended treatment for this disease. Next. Yeah. This is for the primary, secondary cardiovascular outcomes, as we discussed in those graphs here. The primary composite outcome, the number of patients with empagliflozin, number of patients this placebo, and this is the p-value what we discussed in previous graphs. Next. Yeah. So this Emperor reduce effect on individual components of the primary endpoints. Individual components, that is primary composite outcome, fast hospitalization, cardiovascular death. If you see the primary composite outcome less than 0.001. Here, fast hospitalization, if you see, this is again highly significant. But only cardiovascular death, particularly this number of deaths in the both groups, is not when compared, this is not statistically significant. This small trial, small number of patients. If you take large number of patients, there may be significant benefit may be seen, that time will say. Next. So Emperor reduced total hospitalization for heart failure fast and recurrent. These were 353 events in the placebo group, 388 events in the empagliflozin group. Hazard ratio was 0.7. So 30% reduction. Next. So this serious adverse effect in Emperor reduce was significant. It was seen in quite a large number of patients. They were high risk heart failure patients. But this is cardiac. This is related to worsening of the renal function. This is worsening of the cardiovascular. This is cardiovascular disorder. Next. So this is the doses of empagliflozin that lower the risk of CV death or hospitalization in patients with heart failure. This is the 10 milligram, 19.4% here compared to the placebo. This is again this if you take into 520 centers, all class 2, 3, 4 group of NOHA class are included. Median follow-up was 18 months. Diabetic patients were 50%. They concluded among patients receiving recommended therapy for heart failure, those in the empagliflozin group had a lower risk of cardiovascular death or hospitalization for heart failure than those in the placebo group, regardless of the presence or absence of diabetes. Next. Coming to the secondary endpoints, secondary outcomes, we have all described. This is a total 388 versus 553. Composite of renal outcome, you see, renal outcome again 1.6 versus 3.1. Hazard ratio is 50.5. 50% reduction. All cause mortality, this is the only thing which are not significant. New onset type 2 diabetes mellitus and change in hemoglobin HbA1c. Systolic blood pressure reduction was almost around 2.4 versus 1.7 in the placebo group. Confirmed hypoglycemic event was very less, 1.4 to 1.5. Next. So this interpretation, the results of this trial indicate that empagliflozin is superior to placebo in improving the heart failure outcome among patients with symptomatic stable heart failure, that is ejection fraction less than 40%, on excellent baseline guided directed medical therapy, GDMT. So irrespective of diabetic status, benefit is primarily driven by a reduction in heart failure hospitalization. There was also a benefit in renal outcome. This is very important trial as it mirrors similar findings with DAPA-HF trial or dapagliflozin. Even patients with severe LV dysfunction appear to have benefit also. Next. Even though SGLT2 inhibitors were introduced as for the treatment management of diabetes mellitus, the results of EMPA-REG outcome and then EMPEROR-HF and other indicated clear benefit in patients of heart failure management and in patients with established cardiovascular disease, atherosclerotic cardiovascular disease. This trial enrolled a dedicated heart failure population and conclusively shows a benefit in this patient population, irrespective of the diabetes status. This is the main, irrespective of the diabetes status. These drugs will likely have a prominent role in future heart failure management guidelines. Thank you. So if this next, go next. Thanks. Because if you see what EMPA-REG they showed, there is definite benefit as regards ASCVD is concerned, and EMPEROR-HF is reduced ejection fraction is concerned. They took patients with less than 40% ejection fraction. If the ejection fraction is low and take into account the NT-proBNP to keep a identically high risk patients, so that if the ejection fraction is less than their NT-proBNP low or little higher with a higher NT-proBNP, they can take so that they are equally risk. So in high risk patients, diabetic or non-diabetic, this empagliflozin proved to be beneficial as regards the reduction in the heart failure hospitalization first and subsequent, and the combination of heart failure hospitalization and CV death.
Okay, thank you.
Thank you.
There is only one question.
Yeah.
Okay, for you. Sir, there is a question from the audience that does empagliflozin can be used in multiple CV risk factors or multiple in CVD?
Multiple? If there is high
Empagliflozin can be used in multiple CV risk factors or any CVD?
Yeah. You see, EMPA-REG trial, the EMPA-REG trial was on patients with established ASCVD or very high risk for ASCVD. So that was the EMPA-REG trial that definitely proved the beneficial to be in the patients with cardiovascular disease, particularly atherosclerotic cardiovascular disease. So that if there is very high risk, there definitely you are going to use empagliflozin.
Okay. Yeah.
Yeah.
Yes,
if
sir.
there is,
Anything?
yeah, I want to know something from Abhay. Because Abhay, why this hypoglycemic events are so less, 1.3, 1.4%? So is it that this glucose lowering effect is negligible with SGLT2 inhibitors?
Yeah, sir. If you see the mechanism of action, actually, normally what happens, the amount of glucose which is excreted from the particularly kidney, it is excreted to the kidney, and ultimately that amount is actually being reduced from the systemic circulation. When blood glucose comes close to the normal, then two things happens. One thing is it is severely less than the renal threshold for glucose, because when blood glucose is around 90 and postprandial is 130, 140, so it is below 160 because renal threshold is 160. So there will be less amount of glucose will be excreted in the urine. So this is the reason why actually the risk of hypoglycemia will come down. First thing. Second important thing is that whenever you are giving any sort of SGLT2 inhibitors, the glucagon is increasing. This is the one defense mechanism or compensatory mechanism. It causes hyperglucagonemia, and itself glucagon increase itself gives some sort of protection against hypoglycemia. So this is the basic two mechanisms where actually that the risk of hypoglycemia is less. Because normally the renal threshold is 160. If you are using SGLT2, it will actually, that will be a leftward shift. So it will come around 140 or 145, 130 like that. But when the blood glucose comes down below 130, there will be no further excretion of glucose because renal threshold is 130. So once there will be no excretion, there will be no hypoglycemia.
Yeah.
This is the basic mechanism.
Yeah. And the cardiological benefit, as we discussed,
will be there. The pleiotropic
effect the main, because reduction of blood pressure, cholesterol, your triglyceride is reduced.
This is the reason why. This is the reason why actually they are telling Even if in the CKD patients now GFR around 15 to 30, you can give SGLT2. Even if you are not going to get the benefit of low blood glucose or lowering of the blood glucose, there will be no reduction in the hyperglycemia, but you are going to get the pleiotropic benefit of SGLT2 from the renal point of view.
Yeah. So there is definite cardiovascular renal benefit. So diabetic patients are very high risk. So diabetic, yeah, with high risk subgroup and should be taken only for this, SGLT2 inhibitor.
Sir.
Okay, thank you. So we are concluding the session, doctors, and on behalf of Lupin, thank you very much to you both for sharing your experience and sharing your wonderful presentation. And we'll see you in the future meeting. Thank you very much, doctor.
Thank you.
Thank you. Thank you.
Thank you.